Hello, and welcome to the symplr Education Series webcast. Today's webcast is titled, Time for Change, the New Culture of Accreditation, with speaker Patrick Horine. At the end of this session, we will have time for a formal Q&A, but feel free to ask any questions as they come to mind via the chat box located on the right side of your screen. You will also be able to download the archive of today's webcast along with its slides at symplr.com soon, and will receive download information in an email. This Continuing Education Certified symplr Education Series webcast is sponsored by symplr Compliance and Credentialing for Healthcare. Next slide, please. Thank you, sir. Next slide. We are so pleased to have Patrick as our speaker this month. He is the President and CEO of DNVGL Healthcare and is responsible for the North American healthcare business of DNVGL, which includes a growing portfolio of standards-driven accreditation and certification services, and he has more than 25 years of experience. I'm sure many of you know him, and I'd like to turn it over to him now.
Thank you, Callie. Well, I wanted to give everyone the opportunity to really get a better understanding of DNVGL. First, let me start with the name. The DNV stands for Det Norske Veritas, which means, loosely translated, the Norwegian truth. We completed a merger with another organization last year, and it's referred to as Germanischer Lloyd. Obviously, a little easier to pronounce DNVGL. But for those of you who don't know us, we're probably the biggest company you've never heard of. We have 16,000 employees, 500 offices in over 100 countries throughout the world. And really, with our main purpose is safeguarding life, property, and the environment. What we do is basically manage risk, working with different industry sectors and how we approach this with their companies, making them safer, making them better for their customers, and really working to that end. What is really interesting is kind of bringing that same purpose, if you will, to healthcare is actually what has driven kind of our program to change this kind of culture and how we approach it with accreditation. So as we not only got our deeming authority in 2008, but we've amassed over now 400 and some odd 50 hospitals as a part of our certifications and accreditation programs. You know, a lot of hospitals are really kind of appreciating the experience. They're looking to see kind of, one, how our approach is different. Anecdotally, in particular, we know that we're helping organizations. We're becoming more enablers to what they do. But the broader view of DNVGL is really about reducing uncertainty. How do we increase safety and working with the organizations beyond just accreditation, but how can we apply this in ways to improve efficiency? I think one of the things that as we got into working with hospitals more frequently with regard to how we've applied what's called ISO 9001, the quality management system, and how befitting this is for healthcare. But if you look at organizations in the past, traditionally, you know, all hospitals have made improvements in what they do. It's you know, it's an issue of continuous improvement. However, I think what some of the shortcomings are with that are they haven't been able to sustain that over time. And for our rationale in kind of approaching this is how do we bring together a standard that not only meets CMS conditions of participation requirements, but how can we create a quality management system approach that is going to really benefit the continual improvement, that is going to help sustain improvement over time. And that really, in essence, is how we are approaching this to be, you know, a better accreditation organization for our hospitals. How can we do more about not only building your trust and confidence with our customers, but also for the patients at large. So when we got into this really kind of first back in, gosh, it was like what, 2004, 5 in that regard. One of the things that we were really looking at is trying to really create first our accreditation program was what are some of the drivers behind that? Namely, what is the culture of accreditation? You know, we go into hospitals and there'd be a lot of fear for the hospital staff. Nobody wanted to talk to surveyors. Let's keep quiet unless they ask us something. there was that punitive type of thinking that basically led into, let's just prepare for survey. We get into that 3 to 6 month window prior to anticipating survey, so we're getting things ready. And what it was really kind of looking at, and from our perspective, was going through the kind of accreditation exercise. It's really no reflection, if you will, more of what looks like day to day, but getting kind of dressed up for the survey. But the mentality of the hospitals was, let's just fix it, get this survey done, and we'll wait for the next survey. So, if it was this type of thinking, that just fix it attitude, and really not being able to sustain those improvements over time, just get them done to satisfy the survey process, then it really becomes more of an act that what we're doing. And this Aristotle had a quote that was very, very interesting, and we are what we repeatedly do. Excellence, then, is not a act, but a habit. So how do we turn this into some of the habit? How do we incorporate this into the day-to-day activities that we have in place? So for DMVGL Healthcare, really what we want to be able to promote in what we do is, how do we become an enabler? I can't have necessarily a direct impact on HCAP scores. I can't have a direct impact on reviewing infection rates. And I can't have a direct impact on, for me actually touching that. What we can do is be an enablers, creating the quality management system, working with the hospitals as a partner, how we're approaching the accreditation process so that we can get hospitals to open up, and then we can provide some guidance and direction in that way. So it's not necessarily an adversarial relationship as kind of has been experienced traditionally in the past with other accreditation organizations, but how do we go about approaching it and doing it that way? So the thing is rather than the hospital working so hard for accreditation, how do we make the accreditation work for the hospitals? And I just wanted to take you through a few of these kind of ways in which we have really kind of helped in really adapting our approach. How do we help with changing this culture of accreditation by way of standards? How do we conduct our annual surveys versus once every 3 years? How do we gradually introduce the ISO quality management system without a hospital feeling like they're going to have to go through this insurmountable work in order to transition? How do we keep the focus on the processes, the sequence and interactions of processes, and trying to break down some of the silos within the hospitals? And it has to be carried out. I mean, I can speak to the C-suite, I can speak to you on a webinar, and really kind of share my passion that has really kind of driven us to what we've become today. But the surveyor teams have to be carrying this out, and they do so. And if you hear from our hospitals, they will speak about that experience, their interactions with the survey teams. And I think lastly, looking at it from a tipping point, we don't distinguish between differences in accreditation, preliminary denial, conditional, double secret probation. There's nothing in that way to describe that. One, the general public in many cases doesn't even know who the respective hospital they go to, who they're accredited by. And if we put a label, it adds kind of a stigma to that that's really kind of unknown to the consumer. So as such, you're either accredited or you're not accredited. So let me talk about this a little bit and how this really applies from an accreditation standpoint. Now, when you look at our standards, some people will step back and say, wow, these aren't really that cutting edge standards. They're not overly prescriptive. They're pretty much more of the kind of fundamental aspects. That is by design, and here's the rationale why. Is that, one of the things that we've seen is that traditionally, as a part of that ramp up for survey, there seems to be a focus on more of the extraneous requirements rather than the fundamentals. Yet, what by way of which the accreditation organizations are measured is by what comes as a result of a validation survey. During the validation survey, they're going to use the CMS conditions of participation. So we got to, one, break down the disconnect there. But from my perspective, I think where hospitals have lost sight of is more of those fundamentals rather than the extraordinary. If we can build some of the consistency behind the fundamentals of what we should be doing every day, day in, day out, and the staff doing more consistently, that is going to really kind of drive some of the improvement that we want to make, rather than the focus on extraordinary requirements that may or may not bring value. So we've designed our standard that way, understanding though that there are different ways of meeting requirements. It doesn't necessarily have to be prescriptive in order to be demonstrated. And so what I mean by that is there are different ways of meeting standards and understanding the context of the standards and how the organizations are using some innovative practices to be able to demonstrate that. I think one of the key things that we look for is trying to explain the rationale behind the standard. And let me use this for an example. We'll get asked about, well, why so nitpicky? Why do you just kind of scrutinize the documentation of the medical record? Physicians will sometimes ask about this. Why all this stuff about dating and timing in the medical record? Why is that so important? Well, in our perspective, it's not that the medical record is a legal document, a way of just recording activities. We see it as a communication tool. It's the way that we talk to each other in hospitals. So if we don't scrutinize the dating and timing, when orders are present, when medications should be given, when checks and reassessments are done, those are the kind of things that we really depend on as part of communicating with one another, whether it's between, not depending on just what happens between shifts, but what happens throughout basically that continuum of patient care. So when we try to look at it and think about it that way, let's get at fundamentals. Let's try to understand there are different ways to demonstrate this, but have an understanding of the rationale behind the standard. We can really kind of incorporate that into what we do day to day, rather than getting ready for survey or changing our process behind what we want to do to impact this. And oh, by the way, over here we also have these standards to incorporate into this. Let's bring them together. Now, the changing dynamics of healthcare warrant this. No hospital is alike to another. The changing dynamics of healthcare, you've got different kinds of providers, different ways in the delivery system, integrated care networks. It really has to be adaptable in that environment, and how we really kind of accomplish that. So for ISO 9001, and what we've done in this regard is really try to introduce a concept, some methodology to a hospital that can actually work within the current structure that you have. It doesn't mean that you have to throw everything out that you've been doing. It doesn't mean that you have to eliminate approaches you've taken with Six Sigma or Lean methodology, anything in that regard. It plays into the hands of high reliability organizations. And last year we even had one of our hospitals receive the Baldrige Award. So with that kind of thinking, it's really first understanding what's working and what doesn't. There's a lot that hospitals can already demonstrate that already speaks to ISO 9001 and what we're doing. And I think for us, where we saw that it was very befitting was that there are pieces and parts, albeit fragmented in some cases, pieces and parts of that quality management system already there. It's just that we lack some of the formal structures, the formal, forced accountability, if you will, with the effectiveness of the quality management system. But this is the hospital's quality management system based on ISO principles. So it's not necessarily getting rid of everything you do, but finding out what's working well and where we need some of this structure to support that. So what we do is we allow time for that to happen. It doesn't have to be in place for the first survey. We're actually going to allow you to adopt and implement that over time. So by the time we get to the fourth survey, if you will, which is our reaccreditation survey, at that time you'll be basically demonstrating your kind of full success that you've had with ISO 9001 implementation. And we don't just leave you from the first survey and say good luck, but how do we really kind of walk you through that, through the assessments, through the different stages that we look at, providing some additional training and guidance in that regard. We can't consult as it's conflict of interest on our part and really prohibited in the ISO world, regardless of what firewall may exist. But for us, we want to be able to educate, be able to guide, be able to help direct. Obviously, we can't put pen to paper and putting this all in place for you, but I think that becomes really some of the benefit behind this. It doesn't require a lot of additional resources on your part, hiring consultants, bringing people in to put this in. We're healthcare people, and we need to have an in-depth understanding of what we do, how we do it, to be able to embrace this approach. That process approach really fits healthcare. And when they first came out with the ISO standard back in '94, it was more geared to manufacturing environments. When they made the revision in 2000, it was more in line with service organizations, and again made this very befitting for healthcare. So that process approach that we're applying here is really what fits. Now, many people sit back and think, yeah, I've heard about this DMV, but I heard they do annual surveys. I don't like a survey once every 3 years. I certainly don't want one every year. But actually, that demeanor has changed with the hospitals. They have actually come to welcome the annual survey because it basically keeps them on their toes. It is a way of looking at that continual improvement. It is a way of really kind of seeing what progress has been made since the last survey. It is a way of kind of changing the use of the resources and what we've done in the past. So now we can apply these for internal audits. Now we can apply these for following up on the surveys and other aspects related to that, other than putting the resources into some of that consulting effort to get ready for survey. And regardless of whether we're doing it annual or once every 3 years, accreditation is always an assessment of the organization as a snapshot. It is that moment in time that we're looking at. And for us, we get a better feel and understanding for the organization if we're looking at over time, understanding the effectiveness of corrective actions that have been taken, seeing where continual improvement's been made, and then this helps really fostering that habit and becoming more sustainable. So that's really kind of the benefit behind some of the annual surveys. One of the challenges I think that we encounter a lot with hospitals, and that probably the biggest hurdle we have to climb, is what is this ISO 9001? I went on the internet, started looking at ISO 9001, and it looks like it's more manufactured environment. It looks like it's more automotive. I don't really kind of see the connection. It is applicable for hospitals. It is very much driven on the process approach. And they've actually introduced a revision to the standard in 2015 that'll be fully implemented with here in the next 2 years that really even plays more into our hands in healthcare, applying that risk assessment approach, looking at it as the inherent risk that we look at in the environment we work within. But it's all about quality management. It's about how we improve quality. It's about the structures that we put in place. It's about the accountability that we have of others outside of the quality management department, are those that are basically forcing people's hands with accreditation requirements and regulatory requirements. But it's not about just following a set structure. It has to be done in this way. ISO is not prescriptive in that way and not overly bureaucratic. What it looks for is basically how is an organization demonstrating the effectiveness of their quality management system. And this can be done and from the smallest of organizations to the largest in a very less costly, less time-consuming way. But it's more of how the organization elects to adopt this, how aggressive they want to be, how do they bring in others as a part of this. But first and foremost, we want to encourage that creativity and innovation. Hospitals are full of smart people. Unfortunately, there are some organizations that like the prescriptive, that have to have it, say it a certain way, if nothing else, to blame somebody else for making us do this. But those forward thinkers, the hospitals that kind of we brought on kind of with this, have really been enabled to use some of that innovation, to take up some of the things that they've done with the lean approach, Six Sigma, high reliability. How do they tie this together and kind of how they're really kind of building their organizations? I just did a recent presentation for a health system, and really one of the objectives that they had is, I want to start making the connections with the high reliability organizations. This is the approach that we're taking. We're an integrated health network. And, as we started piecing this all together, there is so much tie-in to that. It's just a unique way of going about it, and it ties a more prescriptive standard with that which is the quality management system. So if you look at the context or the way that the ISO standard is structured, it first starts with documentations. Now, I can ask this question rhetorically by way of over the telephone in a webinar, but I challenge you, how many of you think that you follow your policies and procedures just as you've written them? Everybody follows these to the letter. And I'd be hard-pressed to see if anybody's shaking their head in affirmation that we do this. We know that it doesn't happen. We have these works of literature that we put together, yet aren't necessarily followed as they should be. Everyone has their shortcuts. There's different ways of approaching it. In some cases, there are 3 or 4 different policies for one process within the hospital. So let's first look at the documentation. How do we set up these policies and procedures to simplify? How do we take a 30-page policy and procedure and apply it in a 2-page work instruction? And if we were to follow these 20 steps, if you will, consistently every time, we would have a more consistent process. Okay, driven by management commitment, customer focus. How do we plan for, and what are some of the objectives that we hope to achieve? I think in many ways I see within the organizations and healthcare, we established very elaborate goals and objectives that we want to achieve through the strategic plan, or the quality planning kind of perspective. Where the disconnect happens is that when you take that down to the department or unit level, we don't necessarily have our goals and objectives tied to that as a strategic plan. We're kind of off on a tangent, doing some different things. Yeah, there may be some relation somewhere down the road, but not a direct tie-in. So if we're going to really kind of be an impact to that from a survey standpoint, and what are we looking at it from an audit standpoint, where are we at from a quality management system perspective, and being able to achieve some of these strategic initiatives that we have in place, it really has to be driven by some of the objectives we put at the department level. How are we accomplishing that and contributing in that regard? When it comes to that from a management system, we do these in a management review in many ways now, somewhat different and not missing, not including all of the relevant pieces, and there's some things missing. But in this management review, we're really trying to look at the overall effectiveness. And we have these quality councils, quality committees, leadership kind of forums, if you will, where we're looking at quality issues, but not necessarily looking at them in a whole. How does satisfaction drive some of the outcomes? What are some of the follow-up they've got on corrective and preventive action? How are we addressing some of the aspects of what we say we're going to do by way of our policies and procedures, and auditing that to ensure that it's happening? So these are some things that we're doing now in different ways, shapes, and forms, but not necessarily within a structure conducive for this, for that ISO mentality. What about the departments that don't get visited during accreditation visits? What about patient accounting? What about purchasing? Are these important functions of the hospital? Well, it's not to say that, well, since they don't get visited by an accreditation organization, we really don't need them and let's get rid of them. That's not true at all. I mean, these are an integral part of the healthcare delivery system, and they need to be encompassed under the quality management approach. So those customer-related processes aren't just the patient care aspects, aren't just the physical environment aspects, but they're what we do as an organization. So particularly if you're looking at it from an integrated care network, if you're looking at the delivery approach and how we do this with the different providers involved, we have to look at all the customer-related processes. So as we do this year to year and looking at different aspects of the organization, it really becomes beneficial to how we're bringing them in. How do we approve our vendors that we use, whether it's for contract services, whether it's for products, and things that we use with our patients. Patients don't come in for a hip replacement and have a stamp on their leg that says, I had my surgery done at ABC Hospital, but my implant was provided by XYZ vendor. We take responsibility for that. So how do we hold our vendors accountable? What criteria do we use to bring them on? What methods do we use to evaluate them? So that has to be incorporated into that quality management system approach. And that is, in essence, kind of what we're looking for from ISO. How do we take that to that sequence and interactions of processes, understanding now what it is we do and taking that from paper to a reality? How do we bring those support processes into the fold that seem to get lost if we look at them solely from a survey process. How do we break down some of that silo effect that happens? Well, I know what happens in my unit or department, but even though I have to interact with pharmacy and other areas, I really need to be worried about myself. And that is the kind of thinking we need to break ourselves of. When you think about the ISO methodology, the easiest way to think of it is document what you do what you document, prove it, and improve it. Documenting what we do is going to be the policy, procedures, and work instructions that describe, here is our process. Do what we document, are we following it? Do we have different methods that we apply? What variation are we going to allow? Do we allow others to do certain things? And that's okay as long as it's really kind of clearly stated that way, and that is how we've portrayed it to the staff. Can we prove it? Have we demonstrated that we do this? Are we following what we say we're going to do? And when it's not working, when it's not following, when it's different than what it should be, and maybe we've seen some best practices deployed without being encompassed in the policy, how do we change that process on paper so that we can become more consistent? That is, in essence, how ISO is really kind of done within the organization. If you haven't really been able to pick up on this, I am very passionate about what we do. I'm even more passionate about why we're doing it. I think there is a different way to deliver the message. I don't think this has to be adversarial. I think it can be very collaborative and educational in the approach. I've taken kind of my passion and belief and done our very best to instill this with our survey teams. They're the ones that you're going to interact with most. They're the ones that are going to be basically delivering on what I'm telling you, and they've been able to do that. So, not only are we going to hire people that are, based upon obviously the credentials that they need, but their personalities are just as important. How are you able to conduct yourself with others? Are you willing to take criticism while you're at the hospital on a survey? How do you accept somebody disagreeing with you on something you may say? And are you willing to listen to really understand what the hospital's doing before kind of reaching your conclusions or judgment? That demeanor is very important, to be approachable, to be engaging, so that we can get with the hospital staff and really get them to open up. I don't want to hear the $1 million answer. I want to hear what you have to contend with day to day. How can we be a help with that? How can we really kind of help put that in a better understanding for you? And what are some things that we've seen with other organizations, and particularly what we've done, and how we can help provide you some direction on that, different ways of thinking and that approach. So we truly have to deliver this in a way that we are partnering with the hospitals. And if a hospital comes across in thinking that, we need to shortcut these standards, or don't tell the surveyors this, or let them find it on their own, then the only people that we are really shortcutting in the end is the patient. So if we've taken away the stigma of status of accreditation, if we've removed any kind of tipping point, if we really don't have any kind of number of findings that equate to a particular status, and we either accredit you or you don't, that should eliminate a lot of that fear, anxiety, apprehensiveness with the survey process, and now open this up to be able to engage with the hospital staff. So again, taking away that stigma is really kind of more of that change of culture for the organization. How do you react to findings? Do you see them as demerits, dings, things that we've done wrong or bad? Or do you look at these as these are an opportunity for us to improve? Okay, that's really a change in thinking. And so how do we really kind of approach this for what actions we take? How do we prioritize the importance? But I think with this and the way that we approach this process reduces the anxiety. It improves and increases the openness that the staff have, because they don't necessarily need to fear the process. They can welcome it. I'm glad you're here. I want to talk to you about some things that we've been a challenge with, things that we've improved, that we've been very, very proud of. And so you still need to take time to celebrate in some of that. So we're trying to connect this all together, not just in isolation, but how do we connect the quality system to accreditation, all having the accountability to CMS? And it's about really kind of changing this approach to actually managing quality. Today, we do a good job of measuring quality. We don't necessarily do as good a job managing quality. How do we do that better? And this becomes more of that, from conformance or compliance, and turns this into more of a business management process with really that focus on continual improvement. Let me talk a little bit about transition. Everybody's got concerns about transition. What's it take to transition to DMVGL? How long is it going to take us to do this? 6 months, a year, 2 years? How many resources, additional resources, are we going to put on this to make this happen? And a lot of hospitals get shocked when I say, do nothing. I don't want you to prepare for survey. I don't want you to get ready for having us come in or anything of really kind of rearranging things in anticipation of us being there. Because I want to see what you look like day to day. For us, we need to establish a baseline. If it's smoke and mirrors and we're playing that accreditation exercise, we're not going to have a true understanding of what's happening within the hospital. Findings are inevitable. You're going to get them. It's the way that you react to them, and that's why I say probably the biggest transition that organizations would have to make is culture. Is your culture conducive to being able to apply innovative practices without being overly prescriptive in the way in which it's noted to you? Is our culture adaptive to an environment where we take findings as a way to improve rather than the ways just to point out where we've done wrong? Is our culture conducive to being open with the surveyors and coming in and being able to partner with them, talk about some of the things that we're challenged by, and not just going through the accreditation organization? Is our culture conducive to really kind of this new way of thinking, how we approach the process, really gaining a deeper understanding of what we do? How do we encompass others as a part of the quality management system? So it goes without dressing up for the party. And you're going to learn from the surveys, starting first with the first survey, which is basically cursory to ISO 9001. We don't get into that in great detail with the first survey. Where you'll start seeing more of it and kind of where it starts the journey is getting into that next survey. And what are some of the things that we're going to be able to identify, or here's some of your bigger gaps. Here's some of the areas you need to prioritize and focus on as we kind of move through the next stages, finding out what's working and what isn't. Have we gotten to a point where we can depend and rely, if you will, on our processes of being more consistent? That's where the transition is going to come into play. Do we have our document structure set up in a way that we are more in line with, documenting what we do? Is it appropriate? Have we assessed and whether or not we're carrying that out? That's kind of probably where the bigger transition is going to come into play. But I would rather it not be that ramping up for survey, but what are we doing as an organization? How do we introspectively look at ourselves in that way to accomplish that? And so, these are just a few of the comments I wanted to share with you that have come from our customers, unsolicited, but some of the things that we've heard them say and capture, whether they come by emails, phone call, other things that we hear. But, kind of words that jump out at me with this are, we've got a culture of safety. It's no longer a game of hiding things. We're using these internal audits to find waste. We're taking, looking at it from the lean methodology and how we're doing this to really kind of meet what we say we're going to do. It's about changing our mindset from reactive to proactive. How do we get really more transparent? And when you look at, kind of where the reimbursement mechanisms are going, it's not going to be unlikely to see within the next 6 to 10 years that you're going to have the majority, if not better than 80 to 90%, that are going to be in quality-related or value-based measures that are dictating that from a reimbursement standpoint. So the microscope's on us in healthcare. We know this. There's increasing pressure for more transparency. So we're really going to have to be in line for that. So we as organizations need to be more proactive, and we really want to really contribute to that. How can we be, one of an organization to be working with you, not against you, not be punitive, but more proactive, and how do we address that? I think the biggest part really that we've seen from many hospitals is that element of engagement. I hated it when my staff, when I was at the hospital, this is when the surveys were announced, heaven forbid, but, how the staff reacted. People wanted to take off on vacation, call in sick, duck in hallways, get in closets, anything to avoid kind of being asked that question by a surveyor. And I think with us, we've really kind of changed that dynamic. We do want to be more engaging. It's really about kind of working with the staff and really seeing where the improvements have been made, and not just focusing on all the wrongdoing, but taking time to also celebrate where some of the success has been. Have we seen some of this and the improvements that are made? I mean, we take as much glory in that as the staff do in seeing kind of where these improvements have been made. Because in our mind, we see this is not just an exercise with this hospital. It's something that obviously they care about. They respect the accreditation process, and they want to get better. And I think we work obviously to that same end as how do we do this to make things better for your patients. I throw up a slide here, and it's not necessarily for you to focus on the green and the red. And it's also not something that we've done to say, let's take all the best DMVGL hospitals and compare them to the worst of the other accreditation organizations. Not at all. What we tried to do here is list hospitals with the same bed size, if you will, same geographic area, and try to do some of the comparisons between the data. What came out of this most remarkable to me more than anything was to see in some respects where many of our hospitals have started already at the higher level and then making those incremental improvements. We're going to have some that's going to fluctuate, and there's going to be a variation. I would love to say that we have the golden touch to put on every organization to dramatically increase their HCAP scores. What we know in particular in this, both anecdotally and empirically, is the fact that we are helping make a difference with this, and the way that the organizations are following through, the way that they have in fact changed their culture, the way that they have been able to innovate and being able to put some of these things in place that are in fact going to make a difference. And I think for me, that is the most remarkable thing that comes from this. So we're collecting more data to show some of the empirical evidence, to show the impact that we've made on different variables and things that they're looking at, and really kind of be able to kind of demonstrate that marked difference into how we've gone about this. There's been a lot of hospitals obviously coming along, big and small, large systems to small individual hospitals, critical access to the largest of acute. We've had a great following. And as we've crossed the United States and international for that matter, what we've been really kind of doing is seeing these early adopters, these organizations that, I have to be overly grateful of this because, despite the fact of webinars and other means for me to get out and talk to hospitals, our best results and our efforts have come by way of hospitals talking to one another. Sharing their experiences. What has this meant to them? How have they reacted to the change in the approach and what we've been able to do to apply that? That's the thing. Word of mouth has been the best thing for us. But now, there's still a number of hospitals that don't even know we exist, didn't know there was an alternative out there for accreditation and how we've approached this. So I appreciate the opportunity for symplr. And what they've done and kind of the ways in which we've been able to work with them and even with the products that they deliver and how they're kind of helping organizations with this, looking at some of that vendor credentialing, if you will, playing really into that from the purchasing component, applying the criteria and evaluation methods. So these are the good opportunities to really kind of share how we've been able to kind of work with this. So kind of in closing with this, and I'll take time obviously for questions, but with ISO and with us, it's not about perfection. It's about building consistency. It's about the customer focus, about continual improvement. We're not there to play gotcha games, and not really a way to go about this from a clipboard kind of audit approach. We're trying to really kind of get an understanding of the organization, use the annual surveys to our advantage to find out how things can be improved, where are systemic issues that we can identify, and then really trying to see where the actions that you've taken, how that impacts your patient care and their experience, for that matter, in a positive way. So we're trying to do this in a way to develop your system in a way that works for you, your staff, medical staff, your patients, not just necessarily to please us, because we're only there for that snapshot in time. What we can be is, again, that enabler to helping you use some of those innovative practices, helping you in kind of how you approach that. That's really, in essence, kind of what we're trying to do. And hopefully we have that opportunity. I mean, this is kind of, for many of you, first exposure. For some of you, maybe trying to really kind of build an opinion or impression in your mind of should we take this to the next step. But if anything, I appreciate you taking the opportunity to listen in on this. Listen to kind of what we can do for your organization and how we can be a partner to you with that for accreditation. And I'm hopeful that you would give that opportunity. I've included as part of the last slide and the information that will be shared back with you with symplr. If there's ways you want to learn more about us, getting some additional information, certainly I'll avail myself by way of email, my phone number, but certainly take advantage of that, and then we can kind of work with our territory managers and others that are kind of working with these organizations, how we can facilitate bringing you on board. But we'd love to have you, but for now, thank you for taking your time to listen in.
Welcome. Thank you for looking to symplr for general credentialing. What is general credentialing with symplr? It is credentialing the contractors, agency workers, and anyone else your facility needs to credential. This can also include students. So if your facility is a teaching facility that has an influx of new students every couple months, you'll be able to keep track of all of their credentials. Why choose symplr? symplr credentials anyone and everyone entering your facility. With symplr, you know who is on site and that they've met your facility's requirements. Combining this with the new internet-free symplr Pass check-in, symplr is the best, easiest way to track more than just your vendor reps. Individuals have portals to upload credentials, or this can be managed by that company representative. Our team verifies all credentials and runs background checks and government watch lists on both the company and the individual. As administrators, using the analytics tools within symplr, you can delineate your data into groups in order to have the complete picture of who is on site and from where. The check-in process for your facility is unchanged. Still have them scan their badge or look them up. Your check-in staff will still see the traffic light to clearly symbolize that the individual has met your requirements and is allowed to be on site. Within the software, you can see multiple levels beyond symplr's standard access level. In this example, you will see agency nurses, janitorial, and construction, each with unique requirements to access the facility. These requirements are set by you, and new levels and requirements can be added at any time. If you're interested in credentialing more than just your vendor reps, please contact us today at sales@symplr.com or give us a call today at 844-242-4977.
So with that, Callie, I'll turn it back over to you, and if we have any questions or otherwise, if they're going to use the chat line. But again, my email and phone number here. If anybody else has any questions and other things you want to do, Callie.
Thank you so much, sir, and thanks to everyone for joining us today. It looks like, Patrick, that people are still kind of digesting what you presented to them. Is there any sort of closing remark or extra little tidbit that you would like to add that wasn't necessarily in the slides?
No, I mean, I think one of the interesting things is that, sometimes you get cautiously optimistic on how you present this information. For those that haven't availed themselves to the most recent report to Congress that CMS sent, one of the challenges that we've seen some in the past with the accreditation organization is about the validation survey process. CMS is taking a relatively small sample size. They are looking at and kind of evaluating the effectiveness of the accreditation organization programs. So they will sample all of the organizations, and then with that, they basically make a comparison back to the reports. And what we've been able to see is that we had the best disparity rate, 15%, where the average was 45% disparity rate amongst the other accreditation organizations. I mean, I think for us is really kind of demonstrate so that we can meet that. We can meet some of the consistency behind that and kind of what's really driving that result. Honestly, it's not I guess for me, in my humble opinion, not the best way necessarily to evaluate the accreditation organizations, but for us, it tells us that we are looking at the right things. We're consistent with our approach and how we're going about that, and it's building consistency with that CMS region to region. And that's really kind of been, I think, something beneficial that has just recently come available that the hospitals can avail themselves to.
Thank you so much, sir. I believe that's about all we have today, since we don't have any questions that have rolled in. If you have any questions, please submit them to communications@symplr.com. And now I would like to let everyone know that we will be sending an email with the download link for the archive, and you can download its slides as well. We will be sending along your ARM certificate later on. It will come in a separate email, and if you would like to receive it and it not end up in your spam folder, please add communications@symplr.com to your address book. Again, thank you, Patrick, for presenting with us today, and thank you to everyone else that joined us, and we hope that you have a great rest of the day.
Thank you.
Bye.